So good morning, everyone. Hope you had a great evening. I had a great 2 days. Like George said, it's been an excellent seminar so far, and we've been pouring in all this knowledge into your brain. I hope there's some room left, because we're going to pour in some more today. We're going to shift gear a little bit. We've gone from the invasive to non-invasive to invasive ventilation. So this first talk I'm going to have this morning is on some of the newer modes of conventional mechanical ventilation. I think before starting this talk, we discussed yesterday that we are increasingly managing our preterm babies and term babies on nasal CPAP, as shown here by already some older data from the Vermont-Oxford network, showing you in the 90s there is a steady increase in the use of nasal CPAP in babies below 1,500 grams. So the question is, are we still ventilating these babies? And if you look at the number of babies that are actually being ventilated at some point in time during their admission, you can see there is a decline, but it's not that big as the increase is in CPAP. Probably it's lower than this at this point in time. We've heard yesterday from some of the CPAP trials, about 50–60% of the babies still get intubated during their admission. But it says to us that mechanical ventilation is not something that's disappearing. And one of the reasons is, if you look at the breakdown of reasons why babies are on a ventilator, and this is a study we did a couple of years ago in many European centers, maybe some of you participated in this study, where we asked the clinicians on 2 separate days to go into their ward and look to the babies that are actually on a ventilator, write down some of the data on which mode, which tidal volume, but also what's the cause that this baby is on a ventilator. You can see that although RES is still one of the prominent reasons for starting ventilation, many babies get on a ventilator for different reasons, and this is probably why we still need this ventilator for our babies. So whether we like it or not, mechanical ventilation is here to stay, which means that we have to understand how it works, and we have to make it as safe as possible, and look at some of these newer modes. And if you want to define new, you have to define old first. What's the old way of ventilation? Well, we can go back a long time, because IPOKRaTES, already 400 before Christ, did an experiment in animals where he cannulated the trachea, thereby supporting ventilation of the lung. So it's pretty old. A long time later, then these experiments were repeated by Vesalius, who also cannulated these animals, but looked more at the physiology, seeing that if he blow air into the lung, it rises and the animal take up air. So this was a more physiological description of what actually happened if you cannulated an animal and started ventilation. This is all blowing with your mouth in a straw, and Robert Hooke was one of the first that actually used a mechanical device to ventilate, which was a bellow which he could use to blow in the air. Then we have this increase in what we call negative pressure ventilation in the early 1900s. Because of polio, people needing ventilation, and Ian Donald also developed a negative pressure ventilator for newborn babies. And it's displayed here, where you can see the baby in this glass bowl with the head sticking out. And this was the negative pressure chamber, allowing negative pressure ventilation in these babies. It was actually quite a sophisticated machine, because it already had a trigger possibility built in. But pretty soon, because negative pressure ventilation, as you can see, is somewhat cumbersome to apply. And pretty soon, with more polio epidemic coming up in Denmark, people wanted to have a more simple way of ventilating patients. And then you see these positive pressure ventilators coming up the market, also in neonatology. And then in 1966, we have the first randomized controlled trial of mechanical ventilation in newborn infants with RDS. A trial with only 10 patients in each group, where they randomized the patients to either control or mechanical ventilation, showing there was a significant reduction in mortality in the babies who were on a ventilator. There were a couple of more trials coming up in the 70s, all showing there's a benefit of mechanical ventilation in terms of reduced mortality. Now, it's difficult to translate these old trials into current practice, but I guess you will all agree with me that in some babies we actually save lives by intubating and ventilating a patient. So, historically, neonatologists have been using pressure-limited ventilation. And this is because the hardware and the software in the early days was pretty simple, and it could not apply very small tidal volumes or measure tidal volumes in these ventilators. So time cycle pressure limited ventilation has historically been the mode that neonatologists have been using. Let's take a look at how it works. So what we do is we set a certain PEEP level, an end expiratory pressure level. Above this, an inspiratory pressure rise, and this will give you a peak inflation pressure. This is fixed by the clinician. It has a continuous flow to build up the pressure difference, and the tidal volume that is delivered to the patient during time cycle pressure limited ventilation is variable. It depends on the compliance, the resistance, but also the spontaneous effort of the baby during ventilation. And it's time cycled, which means that the end of inspiration is based on the time that is set by the clinician. And this is why we call it time cycle pressure limited ventilation. So why develop these newer modes of mechanical ventilation? Well, one of the major things that people wanted to reduce is lung injury and subsequent BPD. And by doing so, people thought, well, we should avoid high tidal volumes or low tidal volumes leading to volutrauma and atelectotrauma, and we should try to reduce the duration of ventilation as much as possible. A second incentive was to optimize with these newer modes the patient-ventilator interaction, and also optimize patient comfort and to minimize the work of breathing of the patient during ventilation. So these were the main incentives why people were trying to get or develop newer modes of mechanical ventilation. So the first mode I'm going to talk about is volume-targeted ventilation. It's actually a broader term with two of the main modes being true volume-controlled ventilation and the hybrid modes, which actually take some of the principles of volume-controlled ventilation and apply it during pressure-limited ventilation. The idea is that by controlling the volume, you minimize the fluctuations in tidal volume. This will give you less volutrauma and atelectotrauma, and hopefully less BPD. So how does true volume-controlled ventilation work? It's a different modality from time cycle pressure limit. It's been the primary mode that's been used in the adult population and to a larger extent also in the pediatric population. So the big difference with time cycle pressure limited is now the clinician will set a fixed tidal volume, in this case 15 mLs. You still have to set your PEEP. It will deliver this tidal volume not through a decelerating flow, but through a block wave flow, which is different from pressure-controlled or pressure-limited ventilation. And the actual peak pressure is variable now, depending on the compliance and the resistance or the spontaneous effort of the patient. And finally, this is a volume cycle mode, which means that the end of inspiration will start as soon as the tidal volume is delivered to the patient. And the time depends on the flow you set as a clinician. More flow means you reach the tidal volume sooner, so you get a shorter inspiration time. And of course, it depends on the volume itself. So this is a basically different approach of ventilating our patients. So like I said, initially we were not, this could not be applied to newborn infants because the tidal volumes it needs to measure are so small that initially the hardware and the software wasn't capable of doing it. But in the early 90s, this was corrected. We got better hardware and software. And Sunil Sinha from Hillsborough was the first that actually looked at volume control ventilation compared to time cycle pressure limited ventilation. Now this was a feasibility trial, so a small number of babies, relatively mature babies, 31 weeks gestation, and these babies were randomized to either volume controlled or time cycle pressure limited ventilation, aiming in both at a tidal volume between 5 and 8 mLs per kilo. And what they showed is if you randomize these babies, the time to reach success criteria, and these are defined here below, an AAD2 below 100, mean air pressure below 8, or extubation more than 24 hours, were significantly sooner reached in the babies that were on volume control ventilation. So there seems to be an impact of volume control ventilation on the duration of ventilation. However, if you read the paper, you will see that they applied pressure support ventilation during the weaning process, but they only applied the pressure support ventilation in the volume controlled mode. So this might have biased or impacted the results, leading to a shorter duration of mechanical ventilation in the volume controlled group. So following this feasibility trial, they did a second trial, a bigger trial, 50 babies now in each group, younger babies, 27 weeks gestation. And again, they aimed at comparable tidal volumes between 4 and 6 mLs per kilo in both groups. And now they applied the pressure support ventilation mode in both treatment arms when weaning down ventilation. And what they could show is, again, looking at these success criteria they defined in the previous trial. If you look at all babies, they didn't find a significant difference in reaching the success criteria. However, if they did a subgroup analysis in the babies below 1,000 gram, again, they could show that these success criteria were sooner reached in the babies that were on volume controlled ventilation. If you look at the other outcomes, chronic lung disease, duration of ventilation itself, there were no significant differences between the group. They also looked at these babies later on in life, 18, 24 months, and there was a trend that some of the babies that were on volume-controlled ventilation required less inhalation medication and had less symptoms of cough and wheeze. So it seems to be that this effect of volume control ventilation might have an impact even several years after birth. So the volume control ventilation, true volume control ventilation, has been investigated in neonatology, but it's again a very small trial, and I think we need more information on that modality because it's completely different from time cycle pressure limited ventilation. Now the other volume targeted ventilation modes are the hybrid modes. So again, what they did is they take some of the principles of volume control ventilation, especially targeting a tidal volume during time cycle pressure limited ventilation. The terminology is quite diverse as usual. Every ventilator company has its own terminology on trying to tell us how volume targeted ventilation should be applied. I guess we all know volume guarantee, which is used by Baby Luck Draeger. You have pressure regulated volume control ventilation that's been used by Servo, match volume by IVIA. So there are many terminology, and you need to understand what is actually meant with volume targeted ventilation in your ventilator. So there are basic differences between the hybrid modes and the volume control modes. So the hybrid modes are time cycled, so time set by the clinician will end the inspiration. Volume control, true volume control, is volume cycled. This has a decelerating flow, this has a constant block wave flow. This has a plateau pressure, and this has a peak pressure. So there are differences, although they both try to target a certain tidal volume that is set by the clinician. So how does it work? Let's assume this is a pressure trace and a volume trace during time cycle pressure limited ventilation. We set the PEEP, we set the peak pressure, and the machine delivers these pressures every breath. And you can see that the tidal volume is variable, sometimes below the target you wanted to reach, let's say 5 mLs per kilo. Sometimes it's too high. And in the end, if you look at these 5 breaths, only one of the breaths had actually reached the tidal volume that you as a clinician are targeting. And this is typical for time cycle pressure limit ventilation because there are differences in compliance and resistance, and as the baby breathes in, it assists the mechanical breath, and this will change the tidal volume. So the idea is by adding volume guaranteed to the time cycle pressure limited mode is now that the PEEP is set by the clinician, there is sort of a limit of the peak pressure, and the machine is allowed to change the peak pressure depending on the targeted tidal volume. So if the machine starts with this breath, you see a normal tidal volume which is on target. The next breath, the same pressure, oh, the tidal volume is too low. So in the next breath, the machine increases the peak pressure, increasing the delta pressure, and the next one is again on target. Next breath, tidal volume is too high, so then the machine lowers the peak pressure, all within the limits of that you as a clinician set, which means that during volume guarantee mode, 3 of the 5 breaths are actually on target. So you get a more stable tidal volume, less overshoot or low tidal volumes. This has been shown also by some of trials. This is the trial by Marty Kessler, a randomized trial, 18 patients that were randomized to assist control ventilation or assist control with an add-on of volume guarantee. And they looked at the percentage of breath that had a tidal volume above 6 mL per kilo and the number of blood gases with a CO2 below 35 millimeters of mercury. And you can see indicated in blue that the babies that were on assist control plus volume guaranteed had less large breaths with a tidal volume above 6 mL per kilo and less hypocapnia during ventilation. I think you agree that the term volume guarantee is not actually accurate. It's not a guarantee. It's trying to get it as close as possible to the target, but there are still fluctuations in the tidal volume. The group of Bangalore also looked at this, now randomizing babies to SIMV or SIMV plus volume guaranteed, showing that the peak inflation pressures are lower in the babies that are on a volume guarantee mode. And Gianluca Lista from Milano was one of the first that actually translated this stabilization of tidal volume into lung injury markers. What they did is they randomized 53 babies to pressure support ventilation or pressure support ventilation combined with the volume guaranteed, and they measured the inflammatory response in tracheal aspirates in these babies. And they could show that the babies that were on volume guaranteed, indicated in blue, had lower markers of lung inflammation on day 3 of life. So this is the first trial that actually gave us some substrate that this will translate into less lung injury. So there's been several randomized controlled trials. Some of the trials used true volume and controlled ventilation. Some of the trials used volume guarantee ventilation. And they were all summarized in this systematic review with the senior author sitting over there. And what you can see here is the major outcomes on the left, the relative risks here, and the confidence intervals. And just to remember, we need to be on the left side of the one line to have a significant effect. And as you can see, if you look at the outcome combined death or BPD at 36 weeks, there is a significant reduction in this outcome in favor of volume guarantee ventilation or volume targeted ventilation. Number needed to treat is between 8 and 9. They also showed that there was a reduction in the combined outcome intraventricular hemorrhage grade 3 or 4 or periventricular leukomalacia, and also in the number of babies with air leaks. So there seems to be a clear signal in here that adding volume guarantee and stabilizing tidal volume can actually have a clinical benefit in these babies. So to summarize this part on volume targeted ventilation, it is feasible now in neonates. It results in a more stable tidal volume, lower peak pressures, less hypocapnia, and less biotrauma. And the randomized controlled trials have been summarized in a systematic review are relatively small, but they do show a reduction in death or BPD and intracranial hemorrhages. I think there's a signal out there. I think we also have to be cautious because it would not be the first time that a systematic review of several small trials gives you a treatment effect that is not as big or relevant if doing one big randomized controlled trial. So I think these are very interesting data, but we need a larger trial, a bigger trial to confirm these results. And there are still some unresolved issues. We don't actually know what is the optimal tidal volume that we should use in our patients. We don't know if tidal volume is feasible in the presence of an endotracheal leak. Probably if it's a small leak, it's okay, but what if there's a bigger leak? Can we still apply volume-targeted ventilation? And we don't know what the role of volume-targeted ventilation is in term babies, because all of the data out there are in preterm babies with RDS. Okay, let's switch to another mode. That's pressure support ventilation, also one of the newer modes, for at least for neonatologists, because it's been used quite some time in the adult and pediatric population. It's mainly been used as a weaning mode to extubation. It's been around on the neonatal ventilators from at least the 1990s. And the idea is if you apply pressure support ventilation, you get faster weaner from the ventilator and less ventilation time and hopefully less BPD. So the basic principle is that pressure support ventilation supports every triggered breath during either SIMV or during endotracheal CPAP. So you can use it as an add-on for the non-SIMV breaths during SIMV ventilation, or you can put a baby on endotracheal CPAP, and then every triggered breath will be supported by the pressure support ventilation mode. It delivers a preset pressure in response to a trigger, and the end of inspiration is, during pressure support ventilation, it's flow cycled. So just to refresh your memory, here's the time cycle pressure limited ventilation with time cycling of end inspiration. So here we have the flow signal and the time. We have this inspiratory breath. We reach the pressure, the flow decelerates. It stays at 0 because we still are in the inspiration phase of 0.5 seconds. And then we have the expiration flow indicated here in yellow. This means that if there's a plateau or a plateau at 0 flow, this means that the pressure remains up there at the peak pressure for some time during time-cycled ventilation. Now, during flow-cycle ventilation, this is different. What actually happens is that there's an inspiratory flow, and the machine measures the maximum flow during that mechanical breath, and it sets this maximum flow at 100%. And then as the flow decelerates, you can, as a clinician, choose a percentage. When it reaches, in this case, 10% of the maximum flow, the machine feels that the baby is at the end of inspiration and it will give you an expiration. So this is a different way of cycling off the inspiration. This also means that the patient is in control of not only the respiratory rate, but also the inspiration time and the expiration time. Because the baby can take a quick breath or a very long breath, and the machine will adjust the inspiration time to whatever the baby wants, giving the baby more control. It's important to realize that for pressure support ventilation, you need spontaneous breathing, especially if you combine it with endotracheal CPAP. This means that, especially in our preterm babies, that you need a backup rate. So in case the baby does not spontaneously breathe, the machine should sense this and start a sort of a backup ventilation until the baby starts breathing again. Again, there's the problem of a large leak. If there's a large leak, the machine will never reach the percentage of the maximum flow to start the end of inspiration. So you need to be aware of this. Some of the ventilators correct for the leakage, so it measures the leakage, and if you set 10% as a cycling off inspiration, it adds the leakage to that, correcting for it. But if not, you as a clinician will have to make sure that you set the percentage of cycling off the inspiration high enough or higher than the leakage of ventilation. And it's also possible in some ventilators to set a maximum inspiration time. So at a certain point in time, the machine says, no, it's enough now. If the baby hasn't reached the low flow percentage, it will cycle off on time. There's been some studies on how does it work. Does it give you a reduced work of breathing? And it's compared to SIMV or RMV. It gives you indeed a reduced work of breathing by applying pressure support ventilation in this study with a small number of babies, relatively mature. There's been one randomized controlled trial looking at pressure support ventilation in newborn babies. This is done by the group of Bangalore in Miami. These were relatively small babies, 25 weeks, 700 grams, 50 babies in each group that were randomized to either SIMV or SIMV compared with pressure support ventilation. And what they could show, if they looked at the ventilator dependency, the Kaplan-Meier curve, they could show that the babies that were on the SIMV plus pressure support were off the ventilator significantly sooner than the babies who were on SIMV. However, this was a non-blinded study, and there were no strict extubation criteria predefined in this study. So I'm not sure how to interpret this result. And if you look at the babies that were randomized in this study, these were babies that at time of randomization were on an FiO2 of 25%, with an SIMV rate of 24 and a mean airway pressure of 6. So I would suggest, why not extubate these babies instead of putting them on a pressure support ventilation mode? And I think we have to be aware of this. I think pressure support ventilation could assist the clinician in weaning down the ventilator, but it should not delay extubation in our babies. So to summarize this, pressure support ventilation does reduce the work of breathing and improve ventilation synchrony. It facilitates weaning in probably babies that are chronically ventilated. However, at this point in time, the randomized controlled trials are limited and underpowered and lack long-term outcomes. Again, many unresolved issues. What is the correct level of pressure support? We don't know. What is the correct percentage of flow to cycle off the inspiration? If you set it too high or too low, this will increase the work of breathing instead of decreasing work of breathing. And which patients will benefit most? And there are some case reports that babies on, especially preterm babies on pressure support ventilation, have very short inspiration times, and their decruitment is taking place of the lung because of these small inspiration times. So we're not sure how to interpret these results. The last group I want to discuss is the proportional assist ventilation and neurally adjusted ventilatory assist ventilation, or NAVA. Now, Andreas talked about this one yesterday also. The basic aim of both of these modes is that they fully compensate disease-related changes in the respiratory system compliance and resistance by using so-called elastic and resistive unloading. What this actually means that the patient now is in complete control, so not just the respiratory rate or the inspiration time or the expiration time, but also the amount of support that the baby is getting during the mechanical breaths. And the proportional assist uses the tidal volume and the flow to assess how much support a baby wants, and NAVA uses the electrical activity of the diaphragm. If the baby takes a big breath, it means there's a lot of electrical activity, so the machine will give a big support. If the baby takes a small breath, there will be less activity, and the machine will give a small support during the inspiration. If you look at the available studies on this, they're actually quite limited. If you look at proportional assist, there are a couple of studies done by Andreas Schulz looking at proportional assist compared to assist control and showing that the area pressures are lower during proportional cyst ventilation, and you will have an improved thoracoabdominal synchrony in these babies. But to my knowledge, there are no randomized controlled trials comparing this proportional cyst ventilation to other ventilation modes, and no long-term outcomes. So I'm not sure how to use this in clinical practice. And the same is probably true for NAVA. It's a relatively new mode. It's under Servo I. Does anyone in the audience have NAVA in his unit? Are you using it in your babies? No? Sometimes? Okay. There are some short-term outcome studies that show that NAVA actually improves patient-ventilator interaction. It lowers the peak pressure and the work of breathing compared to SIMV combined with pressure support ventilation. And it provides adequate triggered ventilation even in the presence of these large endotracheal tube leaks. Again, no randomized controlled trials and no data on the long-term outcome with this ventilation mode. Important considerations for both is that it requires spontaneous breathing of the baby, which may be less effective if the baby has apneas. There are some reports that proportional cysts might overshoot in case of endotracheal tube leakage. NAVA ventilator is expensive, the catheters are expensive. I do think that NAVA, as Andreas mentioned yesterday, has some potential in non-invasive ventilation because it's an excellent way of triggering non-invasive ventilation. So one of the questions that we wanted to answer is, have these newer modes actually reached the clinical arena? So like I told you, we did this study several years ago as a cross-sectional study in 173 NICUs in 21 European countries. And we collected live data on the ventilation practices in ventilated babies, endotracheally ventilated babies at 2 different dates. We included 560 infants. Most of the infants were preterm babies. This is what I showed you in the beginning. The breakdown was most of these babies were on the ventilator because of RDS, but there were many other reasons to intubate and ventilate these babies. And if you look at the modalities that these babies were actually on, so this is not what people are telling you they are doing, but what was actually happening live. So we wanted to get the live data from those babies that were on the ventilator. And it's pretty obvious that despite the fact that these newer modes are available, the majority of the babies in this cohort that we got from Europe are still ventilated with time cycle pressure limited ventilation. And if you look at the newer modes, pressure support ventilation, volume guarantee ventilation, it's actually a quite low percentage. So these newer modes seem to be incorporated into the clinical practice at a very slow pace. And there are many reasons why this happens. Historically, we've been using TCPL, and doctors don't like to change their practice. If we're used to something, we want to continue with using it for a longer period of time. Might be you need some modern ventilators to have these modes available in your unit. So if you have an older ventilator, you might not have volume guarantee, or you might not have pressure support ventilation as an option in your unit. Maybe it's the lack of strong evidence. If you want to buy a new machine and you have to persuade the people who are on the budget there, you have to persuade them that it's actually going to impact long-term outcome. And it might also depend on the region. We took a snapshot of Europe, might be different in Australia or in the US, I don't know. So to conclude, these newer modes are available and they improve some short-term outcomes in these babies. However, the number of randomized controlled trials is very limited and often includes small numbers of patients. And it worries me because we get these new modes on all these ventilators and people start using these modes. And we don't actually know how they actually work and what the benefits really are. Only exception to me is that volume target ventilation using the volume guarantee gives you a lower incidence of BPD and IVH-PVL. Although it needs to be confirmed, as far as I'm concerned, by a big, large randomized trial. And we know that these modes are creeping into practice very slowly. So what are my recommendations for you? Knowledge of your ventilator. it's important that you understand your ventilator. Each ventilator has a different approach on these modes. For instance, if you apply volume guaranteed in one ventilator, it adjusts for the triggered and non-triggered breath. In another ventilator, it does not adjust for the triggered and non-triggered breath. So you need to get to know your ventilator. I think if it's available on your ventilator, I would use volume guarantee during TCPL, because TCPL is the basic modality also with volume guarantee ventilation, and adding on volume guaranteed will just give you some control on trying to stabilize the tidal volume. I would not go for volume controlled ventilation, which is a completely different ventilation mode, and we need more information on that before using it in the units. If available, you can use pressure support ventilation as an add-on to SIMV if you're still using SIMV, because many of us are moved away from SIMV and now are using assist control ventilation. And I think there's to date insufficient evidence or experience to use NAVA or proportional assist ventilation in our newborn babies. Thank you very much. Any questions? Who is using volume guaranteed in this unit? Who's not? And is there a typical reason why you're not using it? Is it because the machine or the ventilator isn't capable of providing volume guaranteed, or? So you do have the volume guarantee on the Babylog 8000, yeah, but you're not using it because?
Not all the time, it's not using. But sometimes when we use it, the pressure will be slowed down and the machine will be alarming.
Alarming?
Yeah.
You mean on the limit?
Yeah, below the limit.
And what kind of alarm is it? A volume alarm or high pressure alarm or?
Volume alarm.
Okay.
Yeah.
Anton, that was a really great talk. Thank you very much. I have a potential explanation for why the uptake isn't so great, and it relates to your cynicism about the randomized trials, which I share. These are trials that come from units run by experts in volume-targeted ventilation, and they know the tricks of the trade, the things that aren't in the manuals, the things that take you years to pick up. And I think that this question just demonstrates that issue. When people try these modes without knowing everything about the ventilators and having years of experience, they don't work terribly well. The alarms go off, and people switch back to what they've always known. I also share your wish for a large-scale randomised trial where the babies go beyond the units of the experts. I think the combination of an unblinded study run by experts and enthusiasts is likely to give the results that we've seen. So I share your thoughts there.
Okay. Any other questions? Yes.
Do you use the term SIMV plus PSV as equal as SEPPV plus PSV, or is the difference?
No, but I think that if you use SIPPV, which is like a Babylog term for assist control ventilation, this means that every breath is assisted by the machine. So there's no use of, I don't think if it's possible to apply pressure support during SIPPV, I don't think so, because it doesn't make any sense. I think the idea of pressure support is that if the baby is spontaneously breathing between the mechanical breaths, we all feel that it's not a good thing to let a baby breathe in through a straw. You need to give the baby some support. So mainly a lot of people have moved away from SIMV and started on assist control ventilation, and just extubate the baby once the pressures come down and you think the baby's lung is okay. If you do use SIMV, I would combine it with pressure support ventilation to make sure that the non-SIMV breaths are actually supported some way by some pressure taking down the work of breathing in these babies. Okay, no more questions? All right, thank you.